was speaking about working with clients who have a psychiatric diagnosis. I'm going to just self-declare as we go into this topic. It's not a topic that I know an incredible amount about. Looking to you, Rory, to lead us on this one.
Yes, well, I'm going to start by saying that, being a qualified practitioner, certainly if you work for yourself, it's really good to have a working knowledge of what a psychiatric diagnosis is. And I know that through training, we're told that psychiatry and counselling are two different things. But where they do meet is where you take on a client and they come in and they say, I got a diagnosis, I'm schizophrenic, or I'm bipolar, or I've got clinical depression. I think having an understanding of what a diagnosis is and how to work with it. So the first thing I would say is that if you have a diagnosis, it's usually done by either a psychiatrist or a psychologist, usually a psychiatrist. And the psychiatrist is a doctor who has trained in areas of mental health and understands how the brain may differ in some people and give them anxiety or sometimes voice hearing or sometimes areas of either great depression or mania. And to do that, a psychiatrist would look at something called either DSM, which is Diagnostic Statistical Manual, or ICD, International Classification of Diseases. And they're basically books that are published that help a psychiatrist diagnose things. And the thing is, psychiatric diagnoses stick with you for life. It'd be very difficult to have taken off your medical records. It's not like having the flu. And I think why therapists need to know what the terms mean is because, firstly, what we don't want to do is see clients just as a diagnosis and think that everything that they tell us is about their diagnosis. And I think, secondly, is to see the person. Someone might come and say, I was diagnosed with bipolar. What actually does that mean? You could have someone who has been diagnosed with bipolar. I've got a friend who's been diagnosed with bipolar. You would never know. Every time I meet him, he's fine. Privately, sometimes he has very down days and sometimes he's a bit high. But generally speaking, he doesn't take medication. So we have to engage with clients as human beings first and foremost. My message is clients aren't the diagnosis. Clients are the client and they have a diagnosis. We see the client first. My call to action or my call to arms would be to get an understanding of what psychiatric diagnosis is first and foremost. So it doesn't frighten you and we don't see the client just in terms of their psychiatric diagnosis because that's only a part of them.
We see the person, not the label. And I guess a good starting point, if I was to see someone, a client, and they suggested that they had a diagnosis, I might be asking them, first and foremost, what support they have in place and whether that support is aware that they are presenting for counselling. And I don't know if that's a good starting point, but I do recognize that there can be additional risks and that we would need to have an understanding of the diagnosis in ways that they may present. We wouldn't miss cues that may suggest that the person might be in distress. But I wonder now if just by looking at this and saying what I've just said now, if I'm not now focusing on the diagnosis and not the person. And this is a scary line for me, and that's where I am on it.
Yes. Well, I think that's the first thing, discovery, isn't it? And I think if someone is telling you something, there's a reason. As they famously say, all behaviour is goal-directed, as Roger said. And if someone's telling you something, they want you to know. They want you to know that about them. So I think how I would proceed is by very gently just saying, do you want to tell me a little bit about that? And see where that goes. Some people may take medication. Some people may have a regular review. Most people who are in the system, in other words, either with the doctor or under the community mental health team, may or should have a regular review, because if you're taking psychiatric medication, it's usually, in my experience, regularly reviewed. And I think that the people I've had present to me in very general terms, an amalgam of people, is that they could be just to talk about what's happened to them. And I think that's a very good starting point where we work with people with mental health issues, not what's wrong with you, but what happened. Allow people to, talk about what they've come for. They've come like any other client to talk about what's happened. So I think that's a good starting point. But you do have to think about risk. Is someone under the community mental health team, if they say, I've recently been sectioned, in other words, where someone has been detained under the Mental Health Act, or someone has been very unwell, I think one would have to take a view whether you'd want to enact therapy, because as we know with therapy, things can get worse before they get better. And if someone isn't in a stable place, it can make things worse. So I think you have to get the discovery when you meet them. I think you have to just do a little bit more investigation and take a view on whether proceeding with therapy would be in their best interest. And that sounds counterproductive. That's us being the expert. But sometimes you just have to make that call, I think.
I'm also going to share the other side of this. So I do have personal experience with mental health diagnosis within my broader family. When the diagnosis came, they didn't change. They didn't change on how I knew them. They just had some information that certain chemicals at certain times would be produced in their brains that would play out in certain ways. And it was really that. So it was a biological functioning of this person. But what I learned from that is that the feelings that left them with were the same kind of presentations that certainly I saw on a daily basis, which was the bread and butter of counselling and psychotherapy. It's the same kind of feelings, the emotions that person might bring up. And I think that was a bit of learning for me. And you've mentioned medication. For me to be happy, I would need to have a robust assessment in place to be able to ask these questions up front, which should be a standard on any intake assessment, really. Definitely asking if the person is involved with the community mental health team, if they have been previously, and if they have any formal diagnosis, if they're on any medication. It's going to be in your contract. Understand what that is. Do some CPD, have an understanding of what that presentation, including what the medication might do. And I know that both in our student library and in our qualified library, Rory, you created a little booklet, which is like the standard medications that are usually prescribed within the UK and what their side effects can be. I think it's just about seeing the person for who they truly are, but at the same time, maybe having some invisible little triggers that might alert us. So, example, bipolar. If I had a client presenting with that, I might ask them what that looks like for them, because it's going to be individual. You know, if you met one person with bipolar, you met one person with bipolar. Every single person is unique, and it will show for them in certain ways. When a person is well, they're usually able to say how their condition might show up and what some of the triggers or warnings might be. And if they can share that information with us, we can have that invisible little trigger there and maybe weigh in again with that client if we were to see anything or if anything came up.
Yeah, absolutely. Asking the client, so what does that mean for you? Where are you now? And trying to establish what well looks like, because a lot of people who have mental health diagnosis who just get on with their lives. They take medication, or they may do other things. They may be out of situations that cause them to have a psychiatric diagnosis. Trauma is one path to people developing what we call long-term mental health challenges. It is very tricky. And I think for me, it would be, okay, what does well look like? How long have you had a diagnosis? Tell me a little bit about what you do. It's basically getting a sense of how that person's dealing with it. And also, what is it they want to look at? One of the things that we often get asked is, what's the difference between psychotherapists and counsellors? And, you know, I laughingly say £40 an hour. But the fact of the matter is, a lot of the psychotherapists I've spoken to have taken very long paths in training, have worked as their placement in a psychiatric unit. Their placements are in hospitals. So it is about thinking about our competence. If someone came to you, are you competent to work with this? And I think your supervisor, take advice off your supervisor. And there's no shame in gently saying, you know, I don't think my level of skill will match you. You never say to clients, you're too complex, because they think they'll never get help again. But if you say, I think you might want to work with someone with a different skill set, and refer them on. We don't want to work beyond our competence. But as a final thought, many people who have a diagnosis may live their lives quite happily. There's a lot to be thought about. And also making sure you've got the GP's details, the doctor's details. So if someone does become unwell, you've got somewhere to refer. My message would be learn about what mental health diagnosis is, terms like schizophrenia, bipolar, personality disorder. Find out what they are before you proceed. It's always good to have a working knowledge.
Thank you, Rory.
Thank you for watching. I hope you found this video valuable. For more free resources, have a look at our YouTube channel or visit counsellingtutor.com